American healthcare is an outlier. In 2022, the U.S. spent 16.6% of GDP on health, by far the highest in the OECD, and $12,555 per person, nearly double the OECD average, according to OECD and Peterson KFF analyses. Yet outcomes lag. U.S. life expectancy was about 77.5 years in 2022, several years below peer nations, and preventable mortality remains elevated.
Most people are very familiar with the fact that relative to our peers as developed nations, the U.S. has a pretty paltry life expectancy.
Our life expectancy in the United States is dropping. It's dropping and dropping and dropping. From 2019 to 2021, the life expectancy for someone born in this country dropped by 2.7 years. Other countries, maybe it dropped a little bit. The average was 0.2 of a year. There's something wrong. Our country is spending more, much more per capita on healthcare than any other developed country in the world.
The result is a system that spends more and gets less. This episode asks why costs are so high, tracking the history, the pricing, and the incentives that drive them, and why cost control has proved so difficult compared with other wealthy countries.
You've probably heard that the reason people enjoy quote-unquote free healthcare in Australia and the UK and Canada, etc., is that they pay higher taxes. That money then goes into a big pot and is used to pay for people's healthcare. But in fact, in the United States, we spend more tax money per capita on healthcare than Germany, Australia, the United Kingdom, or Canada. That's right, Hank. You pay more in taxes for healthcare than you would if you were British. And in exchange for those taxes, you get no healthcare.
To see how the U.S. arrived here, follow the cost curve over time. In 1960, health spending was about 5% of GDP. By 2020, amid a pandemic and a contracting economy, it spiked to 19.7%. It eased afterward, but in 2023 still reached $4.8 trillion, or 17.6% of GDP. Per the Centers for Medicare and Medicaid Services National Health Expenditure accounts. The long-run driver isn't people using vastly more care, it's higher prices and greater intensity of services. A landmark JAMA analysis led by Joseph Dieleman found spending growth is dominated by price and intensity, not utilization.
Intensity and the price are hard to distinguish for us using the data that we have. The idea is that intensity talks about what's happening at a doctor's appointment or in an inpatient setting. You can imagine that over time, the intensity of care has changed, meaning we've substituted out some technologies for newer, maybe more fancy, and in some cases more expensive technologies. So diagnostics have gotten better, they've replaced old diagnostics, but in some cases they've gotten more expensive. As that changes, we see that we spend more on healthcare. Is that there's a lot of variation in what is driving the increases. And in some cases, it's increases in prices and intensity. In other cases, it's the other factors that are actually driving the increases in healthcare spending. So an example would be in outpatient care, we see that there's a major increase, about an 85% increase in spending between 1996 and 2013.
Earlier work put it bluntly, it's the prices. Hospital and physician services have risen faster than general inflation for decades, and hospital care remains the single largest slice of U.S. health spending.
We've had record inflation numbers recently, but healthcare has started to creep up even more, and we're expecting bigger increases in insurance rates due to the release of new therapies such as weight loss medications like Ozempic and so forth. And the reason that healthcare has just gone up in price is because there are more treatments, therapies, and tools released each year to help combat certain conditions.
The fragmented insurance market amplifies this. Prices are set through thousands of private negotiations, producing wide variation by plan and geography. RAND's 2024 Hospital Price Transparency Study estimated private insurers paid hospitals about 254% of Medicare rates on average in 2022, often much higher in concentrated markets.
Medical costs have long been a mystery. A report from a nonprofit is trying to add clarity in hopes that patients know how much you'll pay when you...
Within the same metro area, commercial prices for identical procedures can differ by multiples.
I have to pay rent and you're charging me $400 for a 30-minute consult, but you don't want me to have stress in my life.
In collection agencies, currently, not including 2020's pandemic, it is up to $160 billion, up from $80 billion in 2016. Most of the states that have the debt are where there's no Medicaid expansion. A lot of people lost their jobs. A lot of people work a couple of part-time jobs. They do not have health insurance. There is no mandate anymore. And the debt is ballooning out there. This is becoming a huge debt problem that no one talks about.
Compared with peers, U.S. service prices are outliers as well. OECD and multi-country price surveys consistently show common procedures cost 2 to 3 times more than in other high-income nations.
So we are actually ranked the very last in health, but we spend the most on healthcare.
Yeah, in developed countries, so
yeah.
Countries that aren't third world countries.
Mm-hmm.
Yeah,
so
spend astronomically more than any of the other countries,
mm-hmm.
way more, and we're by far the unhealthiest.
A gap that has widened over time. And that price gap isn't just about hospitals. It's reinforced by 2 powerful forces: administrative overhead and prescription drug prices. On administration, the U.S. spends unusually large sums just to run the system. A 2018 JAMA comparison led by Irene Papanikoulis found administrative spending near 8% of total health outlays in the U.S. versus 1 to 3% in other high-income countries. And when researchers tallied waste from administrative complexity alone, they estimated $266 to $286 billion per year.
It only takes a glance at a hospital bill or at the myriad choices you may have for healthcare coverage to get a sense of the bewildering complexity of healthcare financing in the United States. That complexity doesn't just exact a cognitive cost, it also comes with administrative costs that are largely hidden from view, but that we all pay. Because they're not directly related to patient care, we rarely think about administrative costs. They're high.
There is between $760 up to $935 billion of waste in the U.S. healthcare system. And this study was what's called a meta-analysis, where they actually looked at dozens and dozens of studies, and they studied the studies. And so the collective sort of wisdom from all those studies results in these numbers. Out of the entire $3 trillion U.S. healthcare system, so you're talking like a quarter to a third of spending is waste.
Some are tied up in things we may want, such as creating a quality improvement program. Others are for things we may dislike, for example, figuring out which of our claims to accept or reject or sending as bills. Others are just necessary, like processing payments, hiring and managing doctors and other employees, or maintaining information systems.
To put that in perspective, the National Cancer Institute estimates cancer care cost about $209 billion in 2020, meaning paperwork and friction likely cost more than one of the nation's most expensive diseases. Drugs are the other standout. RAND's multi-country analyses report that U.S. prescription drug prices average about 2.5 times those in other OECD nations.
There's no reason that we should be paying 3 times other countries pay for the same drugs that taxpayers paid for a lot of the intellectual property, the development of those drugs in the first place. And then we're paying outrageous prices when we actually need to buy them.
OECD health statistics likewise show the U.S. at the top for per capita pharmaceutical spending, around $1,400 per person in recent years, well above the OECD average. Historically, Medicare was barred from negotiating drug prices. The 2022 Inflation Reduction Act begins limited negotiations, with the first set of prices applying in 2026.
Now, nothing has happened. The first impact on prices is 2026. The cap on out-of-pocket expenses, 2025. Nothing has happened to celebrate. It's also not really a negotiation. Oh, there's price fixing. Prices can be 40 to 70% of the average manufactured price. And there's extortion. If you don't agree to the secretary's price, they can impose a 1,900% excise tax on the drug and drive it off the market. But price fixing and extortion is not a real negotiation. And there's no reason to celebrate seniors not getting the drugs they need. Some will be lost due to being driven off the market. Some will have the plug pulled in their development by drug companies facing this future regime.
For now, most Americans still face brand name prices set through fragmented, opaque negotiations among manufacturers, pharmacy benefit managers, and insurers. Layered on top is a fee-for-service payment model that rewards volume over value.
All hospital systems are based, not all, but almost all hospital systems are based in this fee-for-service transactional system, and you need it to some extent. That's how healthcare is run in this country. You just don't need it to be 90 to 95% of healthcare. You need it to maybe be half at most, and you need more of healthcare to shift over into a mindset of outcomes and promotion of health, not just the resolution of sickness.
More codes, more claims, more prior authorizations, and more overhead. Each insurer and provider pair negotiates separately, multiplying contracts and billing rules. The result is a system where complexity itself is a cost driver, one that magnifies already high U.S. service prices and keeps total spending on an upward trajectory. That complexity shows up on household balance sheets, in higher premiums, rising deductibles, and unpredictable bills. For many, the consequence is simple: care gets delayed. According to the Federal Reserve's 2024 survey of household economics and decision-making, 28% of U.S. adults went without needed medical care in the prior year because of cost.
There's a very large concern about the cost of care for the clients that we get the privilege of serving. Typically, the barriers that they mainly deal with is, do I eat or do I pay for my medical bills? I hear that a lot. Or do I pay my utility bill or buy this prescription?
Sometimes when you're talking to patients who are on a limited or fixed income, it kind of comes, do I get it or do I not? And then having that hard decision, do I go with a profound therapy or do I go with a regular standard therapy that my doctor is suggesting here?
The Commonwealth Fund reports that roughly 4 in 10 working-age adults are inadequately insured, either uninsured at some point or underinsured, leaving routine care exposed to large out-of-pocket charges.
Typically, the first thing patients want to know, can I afford this treatment? And if it's a late-stage cancer, I've even had patients say, I don't want to leave this burden on my family. And no one should ever have to make that decision.
Medical debt remains widespread. After credit reporting changes, the CFPB said in 2024 that about 15 million people still had medical collections on their credit files, down sharply, but still significant. During the 2023 to 2024 Medicaid unwinding, more than 20 million people were disenrolled at least temporarily, adding further churn and gaps in coverage.
In regards to advocating for the patient and what questions they should be asking, if a patient is coming in diagnosed with a specific disease category, what our team and what our case managers and myself as well, what we normally try to ask, has your doctor talked to you about this? Has your doctor talked to you about a clinical trial? Has your doctor talked about any other testings that should have been done?
These pressures discourage preventive visits and prescription adherence, pushing problems into emergency rooms where treatment is costlier and outcomes worse.
I think that what I came down to is what's the difference, and it's the way that we provide healthcare. And there's a massive difference between the way we provide healthcare in Australia versus the way we provide healthcare in America. You can look at it in so many different ways. What's the accessibility for people to actually get in and receive preventive services?
The result is a paradox. World-leading spending, yet avoidable financial strain on households, and care that too often arrives late when it's most expensive. Those late, costly episodes are not accidents. They flow from how the system is built. 3 structural flaws stand out: opaque prices, incentives that reward volume, and market power that pushes prices up. Despite federal hospital price transparency rules taking effect in 2021 and broader insurer transparency in 2022, patients still face hard-to-use files and inconsistent compliance, according to CMS oversight updates and recent JAMA analyses. When prices are hidden, shopping and competition stall. Consolidation compounds the problem. Studies reviewed by the FTC and MedPAC find hospital mergers raise commercial prices, while RAND's 2024 employer study reported hospitals were paid about 254% of Medicare rates on average in 2022. Defensive medicine and low-value care add further waste. A JAMA 2019 synthesis estimated $760 to $935 billion in annual waste, with administrative complexity the largest share. Reform proposals target these levers: Stronger transparency enforcement and site-neutral payments aim to curb price markups. Maryland's all-payer global budgets, tested under a CMS Innovation Center model, slowed hospital cost growth and generated Medicare savings. On drugs, the Inflation Reduction Act's Medicare negotiations are projected by the CBO to save tens of billions over a decade. Coverage reforms range from adding a public option or expanding Medicaid in holdout states to single-payer models. CBO analyses suggest overall spending could fall or rise depending on provider rates and utilization. No single fix is sufficient, but a bundled strategy, simpler prices, stronger bargaining, and broader coverage could reduce costs without sacrificing access. The open question is whether stakeholders will accept lower prices and simpler rules to get there.